Good morning, everyone. My name is Annissa George, and I'm so grateful that you've tuned in to this Listen and Learn series, where we continue to be joined by community members to bring awareness about their work that support our Boston residents. You can watch previous discussions on the video section of my Facebook page. Last week, I released my public health plan, which I created in partnership with stakeholders, service providers, and individuals with lived experience to ensure my policy priorities and initiatives are reflective of the realities everyday Bostonians face. I believe that the best way to find solutions to our most pressing issues is by making sure that everyone has a seat at the table. Today, I'm excited to be joined by members of the Mass Nurses Association for a discussion about maternal health. Certainly for me as a mom of 4 boys, I had a number of issues and some serious situations and circumstances through my pregnancies, both with my children and some pregnancy loss. And this topic in particular is really important to me. And certainly before I start, I'd like to thank our Mass Nurses Association for their partnership in developing our public health plan through my campaign, but also for their work every day delivering care to our Boston residents across our city and those that seek care here in the city of Boston. Our guests for today's conversation, we've got quite the crew here with us. We've got Katie Murphy, who's the MNA president and a registered nurse and RN at the Brigham. Beth Amsler, who's a retired RN from Newton Wellesley Hospital and a member of MNA's Congress on Nursing Practice. Kate Cashman, who's an RN at St. Elizabeth's and a member of the MNA's Congress on Nursing Practice, which I want to understand what that is. And Lisa Fields, who's a community organizer for MNA. I'd love to welcome all of you. And I think today we're going to share and talk a little bit about the white paper that the MNA released about maternal health and specifically the need to see maternity services as a racial and social justice issue. Katie and company, I'd love you all to introduce yourselves, but also let's talk a little bit about that policy report and the current conditions of maternal health and maternity services here in the city of Boston. Hi, Katie, welcome.
Thank you so much, Annissa. It was a pleasure reading your health plan. Very, very comprehensive, and I know we really don't have the time right now to talk about every aspect of it, but I just the issues you addressed and the solutions that you're looking at are very, very important. And I just want to make a couple of comments, as you said, about our white paper that we produced in February. Boston is often called the medical mecca for its world-renowned academic medical centers, its world-class universities, its cutting-edge research facilities, and the density of brain power and commerce. But a city can be all that and still have a long way to go to be a healthy city for all. So often the social determinants of health benefit one part of the population while another is lacking to the point where there are real discrepancies in life expectancy and the quality of that life. In February of this year, as we said, the MNA took a look at the state of maternal child health programs across the Commonwealth. And our research found that the access to the full spectrum of maternity care, including appropriate, affordable, and culturally competent prenatal, delivery, and postnatal care within safe, reasonable geographic proximity to their homes was lacking, most particularly in poorer communities and communities of color. As you can see in the report, which is attached, women in these communities are more likely to be underinsured and are overrepresented in publicly funded health systems. Our report highlights the dangerous lack of maternity care around the state due to closures and lack of transportation. But as we in healthcare know, culturally competent care is a vital component of wraparound pregnancy services. This absence is felt in other disciplines, which Annissa addresses in her plan. But in maternity care, someone could die. Lack of adequate prenatal care has been associated with increased neonatal death, low birth weight, and some learning issues. This report is focused on maternity services, but it's really about access to health care, and that's what needs to be addressed. A healthy population is good for all of us. Annissa's plan starts with examining that access to healthcare and the inequities that affect our neighborhoods and communities. Annissa's health plan addresses the full range of comprehensive health services that promote a vibrant population. And most importantly, how to provide that care across the spectrum to every Bostonian. Even as we may be emerging from the pandemic, it did highlight in stark relief how unequal the healthcare system is today. We have to learn from these lessons, develop a plan, and commit ourselves to real systemic change. The model proposed by Annissa would be a model that really could be a model across the state. For example, Annissa discusses the shortage of mental health providers and the high cost of treatment in systemic barriers to our healthcare system. And we look forward to working with the administration of a Mayor Asabi George in addressing these systemic issues. So,
Katie, thank you so much. I appreciate the boosts and the encouragement and the endorsement, both literally and figuratively, of my candidacy and of the work. And it's just really important. Oh, we just lost someone for a moment. They'll come back. But Beth and Katie and Kate, I think all of you have worked in maternity services in one way or another over the course of your careers. Can we talk a little bit about the changes that we've seen over time when we think about delivering high quality maternity services, and how do we better support women, especially women of color, because we know how impacted they are and how poor outcomes are so regularly, they're experiencing poor outcomes on the other end.
Mm-hmm. So I think Katie touched on it, and the most important thing, I think, is the best way to have a healthy outcome is, we talked about, is early, consistent, and quality prenatal care. And I would add, as Katie, I would add accessibility.
Yeah,
I think that's one of the most important issues. If you can't get to the doctor's office or the hospital or the clinic to get your early prenatal care, it's not going to be consistent. You're not going to be able to do it. And I do think we've talked about this, is that culturally competent care is very, very important. And I think some of that gets lost. In my nursing career, I have worked in 5 hospitals in 4 different states, but most of my career has been spent at Newton Wellesley in Newton, and the changes I've seen over the years in what's available in prenatal care, some of it has gotten so much better, and then some of it has gotten so much worse.
And what are some of those changes that you've seen, both in the improvements and in the decline in services?
Well, I think the improvement is in the medical care, and the changes that I work specifically in neonatology. So the changes that we have seen over the years in the kinds of babies that we can save that we couldn't save 40, 50 years ago. And Boston, a lot of the changes that we've seen have come from Mass General and the Brigham, have been started here. But also, I think some things we have seen is access. I mean, I worked in a community hospital that was initially middle upper class, but then we would get a lot of patients from all over who transportation was a major problem. We would get patients who walked into the ER who had never seen any prenatal care. And I'm sure Kate probably sees that even more than we did.
Yeah, I think, at least from my perspective at St. Elizabeth's, we're seeing sicker patients for sure. I mean, we can take care of them because of the advanced technology, but I love your approach to community-based, care.
So important.
Yeah.
Because if these moms were seen in the community and had a rapport with their doctors and were screened for their blood pressure issues, were screened for their diabetes, had their prenatal labs for their sexually transmitted diseases, and it wouldn't be such a windfall of complicated medical issues that are so treatable, and where you live should not decide on whether you should have a baby or not.
Right.
It's the happiest time of your life, and there's so much stigma and stress around having a child now, and it's really a women's health issue. It's almost like it can be disparaging for women to be pregnant. Closing these units is just reprehensible. You have, say that there's one delivery a day, but there's a lot attached to that one delivery a day. There's more than $1 There's a whole family attached to that. There's a mom with 4 boys that depends on that community health center, and if it closes, where is she going to go? Is she's going to come to a big Boston hospital? They're going to have to pay for parking. St. Elizabeth's parking is not expensive, but they're going to have to pay for parking. They're going to have to juggle their kids, the school, the sports, a lot of these people don't have family in the area, have nobody to take care of their kids. So now they're separated. The mom and the dad, or the mom and the support person, can't be in the hospital together. Some people have never even been to Boston, let alone,
Right.
or the incredible odyssey it is to get on the MBTA and get to a hospital.
I think that's a great way to describe travel sometimes as an odyssey. We talk, Kate and Katie, we've all talked about accessibility being so important, so incredibly important. And that's both like physical accessibility, so that transportation issue, getting to the hospital. But then it's also around the cultural competencies and being able to access the care in a meaningful way, and having accessing the information so that you are getting high quality care. And Beth, you mentioned neonatology. My triplets were born 10 weeks, they were born
Wow.
at 30
Wow.
And the care that we received at the Brigham, and the care and the relationship we built with our nurses in particular, because the boys initially had their own nurse, their own team, was
Right.
really phenomenal. And I would say, in many ways, for me personally, obviously a lifesaver for them, caring for them, especially in those early weeks, but a lifesaver for me as their mom, giving me the information I needed, guiding me, and in many ways caring for me. They weren't my provider; they were providing care for my boys. But we talk about maternal health and sort of the risks associated with, especially the risks associated with pregnancy and women's health as it relates to poverty in our community, and how those outcomes are so poor. But then postpartum care, and how important high quality postpartum care is, both for child and mom. And that's all part of it, and the role that you all play. And that's really, really important. And, I think as a society, we've done a better job talking about postpartum care as part of the whole care for the woman and the child. Can we talk a little bit maybe about some of the changes we've seen, or you've seen, in postpartum care?
Well, I think that's a really good Can I speak for one second?
Sure.
Just the fact that you had triplets, and is just incredible that you were able to sustain that. Because you were probably on bed rest.
I'm still trying it.
Yeah, and
I'm 14 right now. I'm still suspensed.
But the issue also is postpartum depression, and when you go for your well visits with your baby, but luckily you were actually in the NICU, so you had a lot of nurses keeping an eye on you, because you were at a huge risk for postpartum depression, all the stress that you were under, and you had post-traumatic stress probably from the delivery and just being there on bed rest. But with well baby assessments for the pediatricians, they're supposed to be screening, at 1 month, at 2 months, at 6 month visits. Now the research is saying going up to 3 years, you can have postpartum depression. So, and there's a difficult thing going on there, because what's the relationship with the pediatrician? What's the relationship? Are you just supposed to come there with a happy face? Are you, or can you be honest with the pediatrician? Do you have a relationship with them? Or are you only seeing them in an emergency setting, or in a health clinic setting, as opposed to a community-based pediatrician that you're kind of emphasizing in your plan? So it postpartum depression can be very difficult, and there's fear and there's embarrassment of attached to it, and people can just go into the shadows and just disappear, and then not go to their appointments, and then not bring their kids to their appointments, because the patient is actually the child, and hopefully the person is screening for this depression when they do come for these appointments.
Right. No, and the mother is an important part of that care.
Yeah.
Yes,
Right. So I was thinking if in community centers, if you really have family-centered care, so you're focusing on the mom and on the baby. And as you probably know, Annissa, if you had twins, triplets that were 30 weeks, then follow-up care as they develop their developmental and early intervention and all those things are so important that they, up until 3 years they do early intervention, but that goes up until school, because sometimes learning disability things don't show up right away. The babies may cognitively be fine, but then you get into the school situation and then you have all kinds of learning disabilities, and that should be followed from birth up. And if you have those services at a community center and you're focusing just on the family, so the mom is getting seen, the babies are getting seen, and you have a support system, and you can incorporate whatever community resources are necessary as the babies grow.
I think
that's
I made a
important.
note that term, family-centered care, because I think that's the way that we should be approaching community health. That is community health.
Yes,
with
absolutely.
It's, as you know, I'm a former teacher, so a lot of my work has found me in the education space. And we talk about all of our work in our schools, and whether it's in our classroom, in a school building, or at the district level, that it's student-centered. And I love the idea that care is student-centered.
So I'm not in maternal child health. I'm in adult intensive care units, but we do see young women who are pregnant who maybe are not getting that care, don't have that access to the prenatal care that you're all talking about. And they're coming in and they're pregnant and they have issues like asthma, which is a huge, huge issue in our parts of our city, some parts more than other. And this is where you really feel that the access to that accessible, close by, culturally competent care would help these young women, these young mothers address these issues, because we do see them in the hospital. I see them on my side, and there's a real absence of that right now in the city of Boston.
So Lisa, I want to get you into this conversation here. I know that you're an organizer and you're working with your nurses across the state, and certainly we're focused a little bit here on the city of Boston. How do you work with nurses and make sure that your members are up to date and sort of involved in and engaged in professional development, especially around these issues?
Well, first of all, so my predominantly region is Southeastern Mass, South Coast, and Cape Cod, which has been particularly hit hard by the maternity desert, so to speak. We've had at least 3 hospitals that have closed maternity services. So the first thing when it comes to, we have within the Massachusetts Nursing Association, we have an accreditation program for licensure. So we periodically run nursing programs. We have feedback. We make sure that our folks are hooked into the nursing programs and keep up their accreditation for their nursing license. So that's kind of one piece of it. The second piece of it is particularly in regards to kind of like people falling through the systems when essential services close. So I'll give you a quick example about what happened in Taunton. So in Taunton, where I live, the maternity department closed. So we went through the process. The Department of Public Health came in. There was a community hearing. The Department of Public Health came back with that this was an essential service to keep it open. Unfortunately, DPH does not have an enforcement piece, so they couldn't force the service to remain open. The hospital came back with, this is what the plan is. We're going to send our patients over to Brockton, to Good Samaritan. So what happened is that not all the patients went to Good Samaritan. That's kind of number one. Some went other places, right? Whoever had access to transportation, that was a big part of it. Whether or not they chose a different provider with a different system, that was a second component. But then what happened over at Good Samaritan is that there ended up being a huge influx of patients that came in. So it wasn't the one baby a day that Morton thought it would be. You know, and I always say, babies don't call up the CFO, the chief financial officer of a hospital, to see whether or not today is the day they're going to be born. There's all sorts of complicated issues. So what we found was there was this huge influx at Good Samaritan. We tried to address that. And then we also found within the community, especially the nurses were the ones that caught it at Morton Hospital, is that there were many members within this community that fell through the system. There's not any public transportation that goes from Taunton to Brockton. So if people didn't have access to a car, that was a problem. What we were finding from the nurses, particularly in the emergency room, was that women were coming in, one, to get a pregnancy test to find out whether or not they were pregnant. Two, then they would come back to find out, to get an ultrasound to find out when their due date was, kind of how far along they were. And then three, to have their babies. So little to no prenatal care. And that was a huge problem, right? Huge problem. We need people to have prenatal care. So what we did was the MNA kind of took the bull by the horns based upon what the nurses, both at Good Samaritan and at Morton, at BID Plymouth, also over at Toby Hospital. So all the kind of area hospitals, and also Broughton Signature Hospital. We pulled together the stakeholders within the city of Taunton. We sent out an invitation, said, let's have a roundtable. And I'm going to be honest with you, when the MNA calls, some people embrace it, right? Some organizations embrace it. And I think you can still hear others running, screaming as they run for the hills, right? Oh my God, the MNA's calling us. So we pulled people to the table, DCF, social service agencies, the mayor's office, the state delegation. We tried to think of everybody. Look, we invited local obstetricians. That's when we found out there was only one left. Everyone else dropped OB, the obstetrics. They only kept the GYN piece of it. There was only one obstetrician still left in the city that took patients in. And what we said to people was, well, let's leave everything else at the door. Let's leave, yes, we're the union that represents the nurses in your hospitals, but let's come to the table and let's figure out how we can address some of these issues. And that's what we did. We kind of linked. We got Good Samaritan to come to the table. We got Brockton to come to the table, Brockton Hospital. We talked about public transportation. We talked about different ways to be able to do that. The big part of it, then COVID hit, right? The big part of it where we were successful was to get people talking, get people thinking, and to come up with creative ways to especially tackle the lack of prenatal services. So that's just one way that we kind of try to link people together to try to come up with some solutions.
That's great. Thank you, Lisa, for that rundown and update on the, it's amazing to me that we don't tune into the people that know the work the most, that are on the ground. And, that's been a big part of my work, is those that are doing the work should inform how the work should happen. And Lisa, you mentioned COVID. If we could talk a little bit about, I'll start with you, Katie, a little bit about how COVID has changed the way that the work is happening. You touched upon it in your opening remarks, but, tell us a little bit about how the day-to-day work, whether it's in the emergency room or in maternity healthcare setting. They call it a maternity ward anymore, labor and delivery. Tell me about how things have changed.
I still call it maternity. I know our maternal child health nurses probably have much more of the updated term. You figure we're now 13 months into this pandemic, and people still do have other issues like having children and having babies. And so I think a lot of resources have been diverted to COVID. We have also had pregnant patients, in the COVID ICUs. And again, we're so aware that this is a population that is vulnerable. Not that pregnant women are more likely to get COVID, but underserved populations. So this is what we found, and we talked about in our report, that the pandemic highlighted the inequities. And so I think some of the things that you talk about putting the healthcare in the neighborhoods will address this issue. If a mother is young and has a couple of other kids, getting across town to one of the big medical centers can be daunting. Whereas if there's a community health center nearby, it just makes it so much more accessible. And so I think in the big picture, yes, we saw how the social determinants of health in our city, and you address them in your health plan: housing, green space, nutrition. These are all connected. And when children are healthy, we all win. We all win. Number one, fewer resources are going to providing the care that children might require, and then and children just do better, and families do better. So this is a lot of the suggestions that you talk about, about access, in the neighborhoods, for all of the services. I think we're really seeing. This pandemic highlighted the failures in our system, really highlighted the systemic racism, and that has to be addressed. And I think, as I said, I have 3 children, and my nurse midwife and my pediatrician were all working women with 3 children. So even I felt that I needed culturally competent care, somebody who understood what my experience. So if I am an immigrant or a young mother who hasn't had access to health care, as a tradition in my family, this is something that a city can provide. A city can provide.
Mm-hmm.
So Beth and Kate, let's talk a little bit about, especially based on your experiences working in maternal health. Let's talk about the things that are missing in your work that the city needs to do a better job responding to, and our system in general needs to do a better job responding to.
Well, I'm fortunately or unfortunately retired before COVID hit, so I have not been in the hospital. But I'm just wondering, and I've asked Kate this, is I know people who held off doing other on cancer screenings and other things. So I think the fear of COVID probably kept people from maybe seeking appropriate care during their pregnancy, going to the hospital. I think maybe that was the fear. So I'm wondering how that has impacted.
Well, one of the actual good things about COVID was that people were coming in labor. They weren't coming in and then being sent home because they were fearful of coming to the hospital. But sometimes they were making that judgment a little too late also.
Oh,
but
okay.
I did notice a lot of racial disparities when we with our COVID patients. There were my first one was a Spanish speaking young girl, and had nobody. And she was pretty sick, and her husband was sick, but they had nobody to help them or navigate the system. And it was really upsetting for her. I mean, we were talking through the interpreter phone, and this was, and everything turned out fine for them, but it's difficult to, you're only allowed one person, which has been, kind of lucky for us, because most of the hospitals and all the other disciplines, they don't allow any visitors. So you're not allowed to have a loved one, but you are allowed to have a support person during COVID. But like I said, again, if you're in a big city hospital and you're out in the community, you've got to rely even on neighbors or just a close friend to help your kids, go to school or do the hybrid thing or go to all their appointments. But I think with basically people are coming in sicker. They're not seeing the warning signs. And like with Lisa's, we're getting a lot of patients from the Taunton area that substance use is an issue. That I think if they had a good relationship with their community-based practitioners, they would be able to not, like I said before, go into the shadows and have the embarrassment and the fear and shy away from treatment until it was a real issue, until it was such an issue that they end up in the ICU with Katie, so I think just, dialing everything back, getting back to the very basics, and just keeping it very local. And then, and I think it's a huge deal if you just go through the screening process and not have people come to the hospital when they're very sick. Pregnancy shouldn't always be, it's not a sickness.
Right.
It's a condition. So, and if you keep yourself healthy, and if you have these community initiatives community-based initiatives to be healthy and to have a healthy family and have a healthy lifestyle, and not rely on, the local convenience store for lunch or for dinner, and, not have these food deserts and maternal deserts, then, it's a quality of life thing. And everyone's entitled to this quality of life. It shouldn't just be certain communities. It should be all communities. Right. And it's important,
And I think that the idea of delivering a baby is, that's not a sickness, and most women can probably handle that almost on their own. It's the pre-care, the prenatal care. It's making sure that you are healthy and have access to good healthcare, high quality healthcare prior to pregnancy, and then certainly during pregnancy, because that is the most critical time. The delivery piece, I think, is manageable. It's all of that care beforehand that's so important to have access to. And, we certainly see through our healthcare system, there is, Katie mentioned racial discrimination across our healthcare system. We see it, in all different systems of any services, education, transportation, economics. It's all there. But when we think about our healthcare system, we think about maternal health in particular, and your white paper speaks to this. The impacts it has, poor outcomes. The impact of the poor outcomes are significant when we think about our Black and Brown communities and our poor communities, and the trauma that becomes associated with that is, it's generational for sure. And I'm grateful for the work that you all do day in and day out to support women, in particular through this time, for sure. And thinking about that, and we keep coming back to that term accessibility, whether it's distance traveled and how do you travel, but also the language piece and the cultural competency pieces. Do we see, there is generally, I think, greater awareness and appreciation for cultural competencies across lots of delivery systems. Have we seen a shift in any maternal practices, any significant shifts in delivering more culturally competent or culturally aware care to women?
I think so. I think that our staff is pretty culturally competent. We have different educational awareness, university things to CEUs to follow. And if we have somebody on the unit that we're not familiar with, we try to do a little bit of research or have some kind of culturally competent follow up with, say if somebody is a strict Hasidic Jewish and they come into the hospital, we've actually recently brought in refrigerators just for them and making certain accommodations for them, or for any other kind of, if a lot of women come in that only want female providers, we try to make that definitely unless, of course, it's an all-out emergency. We try to provide just female providers for those women that need that. And, we do the best we can, and with what we have, of course. But it's an evolving idea, and it's an evolving case-by-case scenario, and we really have to address it more, for sure.
Right.
I think with the diversity of your providers, of RNs, that's certainly very important, both racial diversity and ethnic diversity, as well as language diversity. And, obviously our nurses are highly skilled, highly trained. And when you also bring that cultural awareness through your own personal experiences, as well as the language piece, how important that is to delivering that high quality care. What are you going to say, or Kate?
No,
I think that's excellent.
Yeah, I was going to say that over the last 3 or 4 years before I retired, we had much more a focus on providing more culturally competent care, because we kept our patient population changed, and we see more and more of different ethnic groups and things than we had seen in the past. So I think, like Kate said, it's ongoing. And we did do it on a case-by-case basis, but I think the focus is much more on culturally competent care than it was, say, 10, 15 years ago. And that's only a good thing.
Yeah, no, it's an excellent thing. It's an excellent thing.
I think it all just dials right back to just listen to the patient. Listen to the mom always knows best, right? If something isn't right, she'll tell you, and just go with what she's asking and respect her wishes,
I will tell you, with my triplets, I had I went in, my water had broke, and I won't share too much here on Facebook Live. And so I went, a doctor came in, checked me out. I had a nurse that I had met a previous admittance and during a previous admission. And a few minutes later, I said to the nurse's name was Kathy. I remember her. I said, Kathy, I think there's a baby there. And she goes, okay, I'll let the doctor know. And the doctor's like, no. The doctor's like, you're fine. I was like, yeah, I think there's a baby there. And I said to Kathy, I looked at her, I go, there's a baby there. And she goes, I'll get and because mom knows.
Right.
I told you.
Always listen to mom. Yeah.
But I will say, in that case, I've always had great medical care, but it was my nurse that was my advocate at that moment.
Right. It wasn't the doctor you put in a headlock, was it? It was the
But you know what? I love to hear the stories of the nurses, learning more about different cultures and then providing that as much as we can. It's because, some cultures, half the family's in the room, right? And I know, I'm not a labor and delivery nurse, and that's been incredibly impacted by COVID, right? I mean, you can't have, and I can't imagine being the labor nurse with half the family there, but that's how they do it. And we are really striving to provide that experience as much as we can. Right. But you've seen that completely curtailed by COVID, right?
Yeah. And it's interesting too, because, I keep talking about the good things about COVID, but there aren't many. But one of the nice things about COVID and the limit of guests, if it's the support person or the dad or the significant other, they don't get pushed into the corner. A lot of times when you have mothers and mother-in-laws and sisters, and they are just so surrounded by, with the mom that's having the baby, that the dad kind of gets pushed into the corner of the support person. So that is, it's kind of nice to see just the unit and the three of them working together and, getting to know each other and learning how to be parents. But it does. We do miss it is fun sometimes to have a whole room full of people.
Well, I think we'll be back. We'll be back to that soon, as things start to improve.
Yeah.
But we certainly know, we've had a couple of good laughs here, but we know how serious this issue is.
Yeah.
Certainly as moms, we know how serious this issue is, and through your research and the research of others. And this discussion, this topic has been a discussion for a long time, and we're seeing some strides being made. We're seeing some improvements, but still we know that there are great disparities for women and their health and for children and their health. And it's unfortunately related to poverty. It's related to racism. It's related to just inadequate access to care. So, I continue to be a partner in creating better access to that care with all of you. And I look forward to more work to come. And I look forward to your white paper informing the work of others. So I'm grateful for everyone's time today. Thank you for participating in this discussion. Those of you that are listening at home, if you are interested in offering suggestions for other topics for us to discuss on these Listen and Learn series or in our Community Impact series, please shoot me an email or send a comment to us. We're happy to cover all sorts of topics. Katie, Beth, Kate, Lisa, thank you so much for the work that you do on behalf of our residents every single day in providing high quality healthcare. Have a great afternoon.
All right.
Thank you so much.
you.
Thanks, everybody. Thank you.